we're now at the Q&A section, and we have lots of questions. I'm not sure we're going to get to all of them, but we'll definitely, for the audience, we will, if we don't answer your question, we'll definitely be reaching out to you and sending you our responses. So we'll go ahead and get right into it. We have some questions regarding the analytics portion as well as some clinical questions. So let's start with the first question we have is, how can DoseMe RX be used for research purposes to convince higher administration in the value of DoseMe RX? So I believe Becca and Will, you both referred to some research projects and how you're able to utilize it. So why don't we, I'll turn it over to you to answer that question.
Yeah, well, we just had a student do a baseline from our previous model of trough-based dosing, and then our AKI rates from DoseMe, and showed a decrease in AKIs, and our nephrology team was real excited to see that. So I think that that's something, I mean, even if you can prevent one AKI a quarter, like that's still a huge cost burden. So anything that shows decrease in AKIs, I think, is a big deal.
And Will, how have you been?
Yeah, and I mean, I don't see it as, I mean, research opportunities definitely exist. I really see it more of as a quality assurance, quality improvement kind of thing, and a return on investment kind of argument. You know, but definitely, you know, we have done the internal kind of data lift using our residents and some students' help to show that, you know, without getting into too much of the weeds, that, you know, just implementing AUC guidance and AUC decision making definitely improves untoward renal related outcomes in these populations. And I think, as Becca mentioned, that actually adds up quickly if you look at the pharmaco and economic and medical economics data and how much an AKI costs.
All right, so the next question is regarding the most popular graph, I would say, is the trough versus AUC in our clinical dashboard. So the question one of our audience members is asking is, can you walk through the trough versus AUC visual and describe how you had interpreted it? And I believe okay, yeah. So they're asking how you were able to utilize that and kind of interpret it for your teams that you presented it to. I know, Julie, you haven't had a chance to present it, but I know you reviewed it. So you want to start by commenting on that, and then we'll move over to Will?
Yeah, absolutely. You know, I think one of the great features of the analytics tool is it allows you really to, you know, hone in on certain areas and ranges. And so really at first you look at it and there's a whole lot of information there, you know, different AUCs and different trough ranges. And really what I plan to share with our providers is really to then take that graph as it is and then hone in on that 400 to 600 range and really show how, you know, these lower troughs are truly getting us to those therapeutic AUCs. And so then I would take it a step further and then share our AKI data, because we know that those troughs are, you know, supra-therapeutic troughs, and higher troughs have been really what's associated with that nephrotoxicity. So I would couple that together and share that with the group and really show that this dosing is effective in that manner.
How about you, Becca? Oh, sorry, go ahead, Will.
I was going to say, there's two things I usually call out when we're looking at a graph like that. Is number one, there's obviously a relationship. It does correlate, but the correlation is not perfect. And there are outliers, and it is a wide blob on the map. And so you definitely see those patients in whom trough would work just fine to get you to 4 to 6. But on either ends of the spectrum, you have patients who it just doesn't work that way. And you definitively, the danger patients are those patients that have therapeutic troughs, but their AUCs are way over 600, and those are your AKI patients.
Yeah, I keep going back to the pediatric population because we had such great success there. But look at those little tiny purple guys on the bottom, and they're, you can see that pediatrics, they need really low troughs to hit that AUC. So that's something that, we've been overdosing peds for how many years, and that's something our providers were really, really excited about. So if you want someone that's an exaggerated group to really show this on, look at peds.
I know you all know this, but I'm trained in peds, so that's near and dear to my heart. And I know it takes a while for peds infectious disease groups to convert over. So definitely good visuals for if you're trying to convince them to transition over. So our next question, I believe it's actually for Will, but I think all of you can probably answer this. Are the panelists using it for chronic kidney disease and dialysis patients as well? I know I heard about neuro patients being excluded, but what about the dialysis patients?
Yeah, they're the only population really that we've called out specifically that, let's not go there yet. We do within our education and within our kind of clinical competencies, we definitely talk about patient populations in whom creatinine measurements don't necessarily line up with their actual renal function. And so to be leery of these populations, be leery of populations who have exaggerated volumes of distributions compared to population. But the beauty of the platform is that you have to think about that up front, but then once you get into actually dosing the patient and providing feedback to dose me, i.e. levels, the patient's levels will take over. And so if you provide a level or two, maybe three in a very off the wall, out in left field type of patient from a pharmacokinetics perspective, you can still be confident that you're where you need to be.
Becca, do you have anything to add to that?
Well, you were talking about, those people that you are leery of, or the, cachectic patient or quadriplegic or whatever, and their creatinine's 0.2, and that's not real. So just knowing who are your, and we've had many, many conversations, who are your people that you need 2 levels within the same interval. Get it early, and then you have patient-specific data and you can go forward dosing. So the platform is perfectly set up as long as you have the clinical judgment to capture those patients. You can use the platform perfectly to have good outcomes with them.
I know we're over our time, but I think we can kind of squeeze in one more question, and we'll just the remaining ones that don't get answered, we will follow up with you. So how did DoseMeRx change your sampling practice when you moved to AUC-based therapy? Are you still drawing trough levels? Have you switched over?
We love it. We only send our lab team up once a day with their morning draw, with the exception of those people I just said I got 2 levels on, but you can time one of them with AM labs. So yeah, our lab team is a huge fan of us right now.
Yeah, that's really one of the beauties of moving to kind of a Bayesian level analysis and using a computer to do math, is that it doesn't care. It doesn't care if you're at steady state. It doesn't care if it's a trough. It doesn't care. It just does the math.
And I would just echo that we've moved to random levels with AM labs as well. And one of the nice things about DoseMeRx is that we've been able to use, there's a dosing, like a date and time to start your doses. So for us, our AM lab time varies amongst our units throughout the hospital. So we actually also use that to also avoid AM lab draw times. So we have found that helpful as well when we're trying to not interfere with our AM labs.
That's great to hear. I'm sure your lab colleagues are all sending you presents and candies for making their life a lot simpler, because I know how chasing levels can be. So
our patients too.
Exactly. Yeah, that's true. Well, thank you so much for all of your time. I know that we have a lot going on, and a lot of you all are very, very busy individuals. So I really, really appreciate you being on here. I hope this was very insightful for our audience. we have contact information. In like I mentioned, the answers that we weren't able to provide during the webinar, we will be following up with you. So keep an eye out for that communication, and just want to thank all our panelists today and appreciate your time. Thanks everyone for joining.